Good morning, friends. Welcome to the new video. Before I start, I have to make you a request to kindly click on the video, go to YouTube and like and subscribe, and if possible comment on the video. Give suggestions about the topic which you would like to listen to. Some of the friends from the audience have requested me to speak on tuberculosis. Tuberculosis is a very common disease, particularly in our own country, that is the India. A national tuberculosis eradication program is going on at present, in which direct under observation treatment is given to the patient. Before the patient goes to the hospital or a health care taker, he has infected more than 20 people. Thus, this hampers the national tuberculosis eradication program. Many patients who take treatment, they discontinue the treatment or they stop the treatment when the symptoms improve, considering that they have been cured. This is a major misconception, and we as doctors must remove it from the minds of the patient. I have seen 3 members of one family who were suffering from tuberculosis. The father, who was working in an electric supply company of Delhi, brought his son to me. The son was poorly built and nourished. His chest was retracted. He was having cough with expectoration. There were medium to coarse rales on both sides of the chest. I put the patient on anti-tuberculosis treatment, and within 3 weeks the patient started feeling better. A month later, the father brought his other son who had low-grade fever, mild cough, and his X-ray also showed infiltrative lesion in the right lung. He was also put on anti-tuberculosis treatment, and another month later the father himself came with fever and cough. He also turned out to be case of tuberculosis and benefit with the anti-tuberculosis treatment. A girl came to me when I was working in a hospital with low-grade fever and mild cough with scanty expectoration. Her X-ray chest did not confirm the diagnosis, but her sputum examination showed clear-cut acid-fast bacilli or tuberculosis bacilli. She was put on treatment for tuberculosis and she also benefited. A boy of 18 years was admitted in one of the medical colleges with hiccup. It was the year of 1968. The diagnosis was not clear. Suddenly, the boy coughed while he was sitting in the ward and brought out expectoration. This sputum was positive for AFP, and he was put on anti-tuberculosis treatment. If the features of the patient are odd, consider tuberculosis, because that is one disease which can affect the entire body. I have seen tuberculosis of the lungs in the form of infiltrative lesion, in the form of cavity, in the form of consolidation or so-called pneumonitis. I have seen pleural effusion, that is fluid in the pleural cavity. Pleural cavity is the pleura is the covering of the lung tissue. I have seen empyema, that is the pus in the pleural cavity. I have seen hydropneumothorax. I have seen bronchopleural fistulae. I have seen mediastinal lymphadenopathy. I have seen pericardial effusion. I have also seen tuberculosis meningitis, tuberculosis of the kidney, tuberculosis of the liver, tuberculosis of the epididymis and testis. So friends, tuberculosis can affect any organ and present in any way. The common and important clinical features suggestive of tuberculosis, especially pulmonary tuberculosis, are cough with expectoration. Expectoration means sputum production. Sometimes hemoptysis, which means blood in the sputum. Low grade fever, usually in the evening. Malaise, loss of appetite, loss of weight, and when examined you may find lesion or crepitations or so-called rals in the infraclavicular region or suprascapular regions. You may find signs of pleural effusion if parenchyma is not involved. You may find other signs. In the case of cavity, you may find a cavernous breathing. In the case of pneumonitis, you may find a tubular type of bronchial breathing. Without going into more detail of clinical features, how we investigate this patient? We take a X-ray chest which will show us infiltrative lesion at the apex of the lungs. Most commonly the apex are involved. Why? Because the oxygen tension at the region of apex is highest, and the tubercular bacilli are aerobic bacilli. They need oxygen for their quick growth. If there is a doubt, the CT scan can make it clear. If patient is having sputum production, sputum should be tested by making a smear and staining it with Ziehl-Neelsen stain. The tubercular bacilli will look like red dots. How does it spread? Tuberculosis spreads by fomites, which are formed when the patient with tuberculosis coughs. These fomites, when inhaled by any person, will go in the lung alveoli and create a reaction there, bringing macrophages and lymphocytes. These macrophages differentiate into epithelioid cells and multinucleated giant cells. These multinucleated giant cells are specialized type of giant cells called Langerhans type of giant cells, and they are a characteristic of tuberculosis. In this cell, which is of large size, the nuclei are arranged like a horseshoe shape. If this does not help, a CT scan may help. The important thing is to have a culture of tubercular bacilli, because the resistance to drugs is becoming a problem, and culture sensitivity must be done in such cases. What is primary tuberculosis? Primary tuberculosis is the infection in a previously uninfected person or tuberculin negative person, this produces a self-limiting febrile illness. There are two strains of tuberculosis or Mycobacterium. One is Mycobacterium bovis, which produces disease in the cattle. The other is Mycobacterium tuberculosis, which produces disease in the human beings. Now, Mycobacterium bovis can also produce disease in the human beings if cattle milk is used without sterilization. Now, these bacilli which has gone to the alveoli with lymphocytes, epithelioid cells, giant cells, they form a granuloma. In the center of the granuloma is caseous material. This is called caseatic necrosis. Similar reaction may be seen in the lymph nodes. If this nodule becomes encapsulated by fibrous tissue, then the disease halts there. Some calcification may also be seen in the X-rays. Numerous granulomas form together what is called cone focus. Cone focus is a pale yellow caseous nodule, usually a few millimeter to 1 to 2 centimeter in diameter. This is characteristically present towards the periphery of the lung field. A cone focus along with hilar lymph nodes is called primary complex of Ronke. Look at this diagram. This is showing you the acid-fast bacilli or AFB. See this red dot. I am trying to highlight it with my pencil, acting as pointer, and there is an arrow also coming here, which is showing that this is the acid-fast bacillus or AFB. If you go, you find acid-fast bacillus here also. So there are at other places also. This is what you see under the microscope if the patient has got tuberculosis. If you see in the X-ray, that is what you see. Now see this. This is the all tuberculosis focus along with hilar lymph nodes. See, this is how you see it in the X-ray, and look at this diagram. This is the focus. From here it can go to the hilar lymph nodes, it can go spread to the parenchyma, it can go to the pleura, and it can go to the mediastinal nodes. What is primary tuberculosis? Primary tuberculosis is said to occur when bacilli enter in a non or uninfected individual. That means this person is tuberculin negative. It produces a self-limiting febrile illness. There are two strains of Mycobacterium which infect human beings. One is Mycobacterium bovis, which produces disease in the cattle. It can pass from the milk to the human beings if the milk is not sterilized before use. The other is Mycobacterium tuberculosis, which produces disease in the male, in the men, in the women, in the human beings. This is spread from patient to patient by forming fomites are by producing aerosolized droplets. This occurs when the patient with tuberculosis coughs, particularly those patients which are sputum positive for AFP. But even sputum negative for AFP can also produce fomites with this thing, because if the bacilli count is low, they may not appear in the sputum, but with fomites they may come out. This granuloma in the lungs is called gone focus, and these gone focus along with the hilar lymph nodes form what is called primary complex of Ronke. What is latent tuberculosis? In this case, the bacilli are present, but they are in dormant state. The patient is non-infectious, but these bacilli can become active, start growing, and the person can become infectious. They are detected by immune responses they produce in a person. Now, what is MDR? Term commonly used, multi-drug resistant tuberculosis, is the one in which bacilli are resistant to rifampicin as well as isoniazid, with or without resistance to other drugs. Extensively resistant multi-drug resistant tuberculosis is one where bacilli are resistant to rifampicin, isoniazid, one of the fluoroquinolones, and one of the injectable second line antituberculous drugs. When there is no drug resistance, the patient becomes non-infectious after 2 weeks of treatment with antituberculous drugs. How do we treat tuberculosis? You are probably aware that 4 drugs are mainly used in the treatment: rifampicin or rifamycin, isoniazid available as Isonex tablets, pyrazinamide available as pyrazinamide tablets, and ethambutol. In the first 2 or 3 months, 4 drugs, which are the primary drugs, they are given, usually in a single dose together, empty stomach, and patient should not eat anything for at least 1 hour after consuming tablets. The treatment of tuberculosis is slightly different than other infections. Here we give all medicines together to achieve, we give it empty stomach to achieve maximum concentration of all the medicines in the blood to make effective impact on the tubercle bacilli. We don't go round the clock, create a blood level around the clock. We don't use single drug. This is very important. We use 4 drugs to begin with, and when the symptoms improve, or if sputum was positive, sputum becomes negative, then we reduce it to 2 medicines, rifampicin and isoniazid, for another 4 to 5 months period. A total treatment in a responsive case is about 6 months. Now, what is the rationale behind using 4 drugs? It has been estimated that if there are 1000 tubercle bacilli in the lungs and you use 1 drug, the chances of this bacillus to be resistant to this drug is 1 in 1000. But when you use 2 drugs, the chances of the bacilli to be resistant to both these drugs are 1 in million. 1000 into 1000 is million. So 1 in 1 million bacilli would be resistant to both these drugs. Similarly, when we use 3 drugs, it becomes 1000 into 1000 into 1000, which means billion. So 1 bacillus out of 1 billion bacilli would be resistant to all the 3 drugs. And when we use 4 drugs, simple to make it out, that 1 in trillion bacilli would be resistant to all the 3 drugs, all the 4 drugs. Now friends, these are the outline I have given you about the treatment, and hope this will help you. There is no end to reading. You can continue to reading. There are newer tests are coming up, doing from the RBCs, doing from the plasma to detect the tuberculosis at the earliest stage, to do sensitivity. Newer tests are coming. I have no time here to go into details of all these things, because each of these things will require a full lecture of about 1 hour. So friends, I leave you here, and next time I will be coming with another interesting topic. Meanwhile, if you have any suggestion for the topic, please let me know. And also please let me know how can I send you the link of my new video, whether on WhatsApp or some other source. Kindly inform me. Thank you very much.